great pleasure for me to welcome you to the 40th anniversary of the Health Services Research and Development Center. And some of us don't think we're old enough to be in a center that's 40 years old and to have been there near the beginning of the center. And luckily we have people here who actually know how the center started. I'm looking at Dr. Flegel over there, so you'll hear some for the days that date back even before. It's always fun to me to be able to have a chance to look back and to look forward. And by looking back, many times think about those lessons and things that we can gain as we look forward into the future. We are audio taping this, and so we'll have a DVD to share with people who couldn't be here, who would like to hear this. And there are people who had hoped to join us, but just turned out couldn't be here that time. So let me start, and you'll see the first slide here says that Dean Clegg is going to say some remarks. So I'm going to come back to that slide, because the Dean will be here shortly, and then we'll see how much flexibility. And so one of the things, obviously, you learn in academia and research is to be flexible, right? And so that's what David Levine tried to teach me many years ago. You have the program. I hope everyone has a copy of the program. And just to remind you, what we were going to cover very briefly was to really think a lot about what is that next step in research. Is once you have the findings, once you've learned about an innovation and you've produced evidence about that innovation, how do you translate that? What do you do with it? And when I came into academia, I would have said the answer was pretty simple. You know, the expectation was that you published it. And even today, many times, people say, well, publishing, that is really the most important part. But increasingly, we're recognizing that if we're going to help make a better healthcare system and better health for all people, it's got to be more than that. And it's actually, we've got to work on translating those things where the evidence is very positive and supporting into practice and to make them available to all people. And so Dean Clegg has just arrived. And so we're going to move back here, one slide. And it's a great pleasure to introduce, and he does not need any introductions, Dean Michael Clegg, and he very graciously agreed to say a few things about the center and to kick off the symposium.
So, well, thanks. Sorry I'm late. Man, it's hard to believe 40 years. I mean, not that I've been here that long, but you know, I want to welcome everybody to this celebration. And you know, one of the first people I met when I came to Hopkins as a student was Sam Shapiro. You know, and we learned about the HIP trial and EPI, and then got to meet Sam. And you know, for me, he was a symbol of how you can incorporate research and evidence into practice and management. And so, and then I got to meet Don. And I have to say that we're really proud of the center. We're proud of your accomplishments and everybody who's been associated with the center. And there's lots of people, faculty and non-tenure track faculty, who sort of cut their teeth in the center and then have gone on to great things throughout the school and elsewhere. So even though I'm late, it really is a special thing for me to be here and to participate in a very little way. So congratulations.
Sure. Thank you very, very much. So just so you look at the agenda, we're going to talk about translation. I and some others will give you a brief history of the center. And so you'll hear different versions and different stories. And so everyone who's had an affiliation with the center has probably a little bit different story. And I had asked, and will in a moment asked Dr. Levine to come up and talk about the early days. But I had hoped that Charlie Flegel wouldn't be talking to David Levine, because Charlie's going to talk later. You know, and so I don't know, we may not get the two different stories I'm looking for. They may have actually got one story together. We have a fantastic keynote speaker who will help us think a lot about evidence and how evidence plays into management and the kinds of decisions we're interested in and seeing what we've learned actually translated into practice and to management. We have some translation case studies, 3 that we've picked from the center and center relationships to illustrate what we've done and to get a discussion going about what are the facilitators, what are the barriers to translation, to taking that next step and to putting something into practice. We have a closing session where we're looking back and looking forward, and then a celebration after that. upstairs in the Feinstein room, a reception following the symposium from 5 to 7. And so I hope you'll join in all of that. We also want to make this interactive. And so in the schedule, there's time set aside for questions, answers, comments. So I'm hoping that it's not just the person at the podium who is part of this, but that all of you will participate in this. And there may even be a lavalier mic or something that we can use to hand out to people so that you can get recorded as part of the recording of this session. It was striking to me many years ago when Uwe Reinhardt, who is a health economist and professor at Princeton, made the argument that one of the important roles for health services research was to serve as the auditor of the healthcare system. And so much like you think of accountants auditing the books and the records of a corporation and looking at how they're doing and making an assessment of how well, that's a key function in the field. And indeed, if you look at many of the kinds of research that people have published over the years, a lot of it does talk about what's working, what isn't working, and particularly what isn't working. And these days we're working on quality metrics, many other things to help us be able to measure performance. More recently, people have become more concerned that the field needs to move more aggressively in the other role, and that is the role of taking innovations that are coming out of the thinking of researchers working with clinicians and care settings, with public health agencies and others, that generate evidence about how well they work and actually translating that into practice. And so I think when you look at the health reform legislation, when you look at the new CMS Center on Innovation that is supposed to lead the way within the Medicare program in doing demonstrations on the innovation in healthcare delivery, this idea that we have to take it the next step and we have to really do our best to translate what we know works to the benefit of all people. So the goal of the symposium, as I see it, is to examine the facilitators and barriers to the translation of evidence-based innovations into practice. And using case studies drawn from our own experience, we're going to try and look at what lessons there are to be learned for the future. And I hope you as the audience will also participate very much in giving us the benefit of your own experiences. So it isn't just those things that have occurred in the center, but may have occurred outside and you've participated in. To start you off with the early history, and this is where I'm sure Dr. Flegel, when he gets up later, will make sure I've said it correctly. But this was my construction of the early history going back to documents. There was created at Johns Hopkins the Office of Healthcare Programs, and it was as a focus on primary care because the institution was seen as an inpatient setting with an outpatient department. Some people weren't certain the outpatient department in those days was a very friendly place, but it had about 110 different clinics. Those clinics, like the emergency room, operated some 7 by 24. Others were a half day a week. They were a research clinic, were very specialized patients. And the conviction that medical education and the commitment of Hopkins to the community needed to move into primary care. Dr. Robert Heisel, and many of you had a chance of actually knowing Bob while he was alive, went from being the head of the Office of Healthcare Programs on to being president of the Johns Hopkins Hospital for many years. And if you've gone to the outpatient facility near Caroline Street, it is named after Bob Heisel. And many of you may remember him. Was the first director of the Office of Healthcare Programs, and then he was the one who recruited Malcolm Peterson, a gastroenterologist, who sort of gave up gastroenterology and became very interested in healthcare delivery issues as the first director of the center. What was interesting about the center and interesting about the field of health services research was the center went out and purposely recruited a multidisciplinary faculty. And so I had the distinction of being the first operations researcher, as far as I can remember, within that faculty. A real effort to bring the disciplines together. And so today, where we talk about many fields being interdisciplinary and multidisciplinary, health services research was seen from the very beginning as benefiting greatly from a multidisciplinary approach that brought clinicians together with sociologists, with economists, with operations researchers even, with epidemiologists, and many of the other sciences. And so when Dr. Levine comments on the early history in a moment, he may tell you a little bit about what it was like trying to get all of us to learn the same language. And in many ways, it was very difficult because we would talk about the same topic, but use very different terminology and think about it very differently. In that first decade, we undertook in the first 5 years, from 70 to 75, what I would call development with a big D. And so truly the Health Services Research and Development Center was developing. They were developing training programs. Archie Golden will be here a little later. Archie really led the efforts on defining what it is a health assistant and health associate ought to do. A health associate was very much like a nurse practitioner, but you didn't have to have a nursing degree in order to be in the health associate program. And for a while, after Malcolm Peterson left the Health Services Research Center and moved on to being head of the School of Health Services, a school that existed at Hopkins for less than a decade, was training health associates, health assistants as new types of healthcare providers. In many ways, we take it for granted now that that is part of healthcare delivery. We got involved in things like pharmacy utilization review, or the whole idea of utilization review, applications of encounter management information systems, quality evaluation tools in primary care. And during that period, Sam Shapiro became director. And in between, we had an interim director who gave us leadership for about 6 months as the committee that Dr. Flegel chaired. He chaired the search committee that found Sam Shapiro for us, came on board. There was a shift then in 76 to 80, and that shift was very important because it made us much more of a research organization. So it was development and really evaluation and research. And that was to focus more on evaluation and measuring the impact on cost and quality. So we had a distinction, this center, as one of only 2 centers in the country that time that got 2 consecutive 5-year grants from the National Center for Health Services Research and Development. And these grants were to be a center. You had to have a focus. Our focus was primary care, as we'll talk about. But you had to have a multidisciplinary center. You had to have a general health services research center. And out of the final report of that first 5 years, I took a quote that Sam Shapiro wrote that said that the center focused on the assessment of quality, utilization, economics of primary care, and how consumer, provider, management, and structural factors, as well as sources, methods, and levels of payment influence the results. You know, we would be likely to make the same statement today that if you said, what are you going to tackle in primary care? In many ways, it's the same issues, except the technologies are different, the context is different, the capacities of medicine are far, far different. We worked primarily in 3 settings: Columbia Medical Plan, which those of you who remember back to those days know that the Columbia Medical Plan was created as a joint venture between an insurer, Connecticut General at that time, and Johns Hopkins. And so in the new community at that time of Columbia, Maryland. And we had researchers on site there. And so one of them will be here today, Dr. Al Mushlin, shortly. A creation of the East Baltimore Medical Plan. The Johns Hopkins University worked with the East Baltimore community that set up the East Baltimore Community Corporation, and under that, the East Baltimore Medical Plan. And Johns Hopkins physicians mainly staffed that, but it was run by the community and qualified for HMO funding through the government at that time. And again, we did research there. And the Broadmoor Orleans Health Center, which was much more of a sort of a community health clinic, were settings in which we worked. I started looking back, thinking about the faculty who started their careers in the center back in those days. And so I have to apologize to the faculty who started their careers more recently in the center. But just some of the names that stretch back more than 15 years or more, so not all to the first decade, because Kevin Frick will tell me he's not that old probably, and so what are you calling me that old, you know? But Maureen Fahey is here, Kevin, Nancy Fink, who's in the Welch Center today, Pearl German, who's a professor emerita, could not be here today, David Levine, Ellen McKinsey, who's chair of HPM today, Joyce Mayman, who went off to Italy and has been doing work in Italy and married and happy there, Laura Morlock, who's deputy director of HPM and director of the RPH program, Marie McCormick, who is an endowed chair at Harvard in pediatrics, Agnes Rupp, who's at NIMH, Al Mushlin, who'll be joining us at Cornell, Ann Skinner, myself, Jonathan, Sheila West in ophthalmology, Albert Wu, Ann Zauber, who hoped to be here but couldn't at the last moment, Sloan Kettering, and there are others. And so just as Dean Clegg said, the center has been a great place for many of us to start our careers. Some have stayed, many have moved on. I will leave it to you to conjecture whether or not moving on is better for your career or staying. So there's an interesting question always. So I would like to turn to David, now that I've set the stage for the first decade. So Dr. David Levine, if you'd come up here and share some reflections. David is professor of medicine, and I went to the university website and it says you're currently the director of general internal medicine. How many jobs do you have, David?
Just a quick note about how updated our websites are. I haven't been the director of that since 1996.
See, I thought so, but I thought, well, maybe you'd come back again.
And Mike, 40 years? That's nothing. Oh, no, that's nothing. That's really nothing, yeah. Well, Don, thank you for inviting me. I am delighted to be here. I actually am at the stage of life where I'm delighted to be anywhere, but I'm particularly delighted to be here. The earliest recollection that I can give you of the Health Services Research Center, I got initially from Malcolm Peterson, who was the first director. And at that time, Malcolm and I were both working as physicians at the Broadway Orleans Clinic at that time, which was part of what would now be the JHHP. And I was doing doctoral work here in behavioral sciences. I had a Carol right next to Dawn's and one right next to Pearl German. They, Pearl, as she did with many people, carried me through the doctorate. Malcolm kept talking to me, this was 1969, 1970, about this new entity, Health Services Research, that he was directing here. And basically the message was, this is going to allow us to wrap our hands around the major health problems and solve them, take the knowledge and really solve them. Well, you know, I'd say 40 years later, the Health Research Center here, Health Services Research Center here, has made incredible contributions toward that. The problems, I think, got a little larger than Malcolm's hands or my hands or anybody else's, and they're still there. But the approaches that we used, I think, are still very appropriate. The first, it was my introduction to Health Services Research, which I really didn't know what it was, even though I got an appointment there. It was an introduction to me to a real team approach, not a clinical team approach, but a investigative development approach with all of the different individuals and types of disciplines there. We did have some language problems, but they were good problems because it informed a lot of us about other ways of thinking about things and the importance that people from different backgrounds, different strengths, different thinking methods, different disciplines could bring to a problem. And I think a lot of us had never really encountered that in that way before. And Health Services Research, that's probably one of its major contributions, is that it brought that. And then thirdly, I began to understand a little bit more about the organization and delivery and payment and services, all the kinds of things that as a physician, at least in those years, they were all around you, but you really, I don't think, had very much insight to them. It was also an incredibly supportive group, which it is until this day. And even if we weren't that successful in all the work we did, we enjoyed working with each other. We had a lot of fun there, and I think that's one of the reasons that there's been so much sustainability. Even individuals who have left have kept a very close contact. Malcolm, as he wanted to, became dean of the School of Health Services, and I served on the search committee that Dr. Flagel chaired. Again, I think I was on there because they needed somebody junior on there, and I really fulfilled that role completely. I was clueless, and we were trying to recruit this man, Sam Shapiro, and I'd been in this center for a couple years, and I had to read about Sam Shapiro, which shows you how little I knew about health services research. And when I read about him before I met him, I thought, oh my God, you know, this field really is something. And I was really even more excited to be there. Sam came, and, you know, as you can say, the rest is history. And then, fortunately, while Sam was still here, and then after his death, Don has taken the reins and continued this outstanding entity that's so important. Two quick things I'll mention. I'll apologize to people who have heard this before and been in the center, but just to let you know that we mix seriousness with good fun and expression. One of my earliest introductions to really rigorous health services research was through Sam Shapiro, when we had a visiting faculty member from Canada, John Hoey, and I, and we got together one night. We had dinner, a couple of drinks, and we put together what we thought was an incredible health policy plan for healthcare in this country. I mean, I can't imagine thinking back. But anyway, it's that we did it is not so astounding. What's astounding to me in retrospect is that we brought it to Sam Shapiro the next morning and told him we wanted to submit this for funding to Health and Human Services. And Sam, who I love to this day, bless him, looked at both of us very charmingly and said, let me ask you only one question, because he had read it. He said, do you have any advanced knowledge that the people that will review this at the other end are absolutely stupid or have no idea about this field? That was one of the best messages I ever got about health services research. I think I really started learning after that. The other is, at that time, as Don mentioned, we were particularly involved a lot with what then was experimental medical approaches, looking a lot at health associates and physician assistants at the Columbia Medical Plan, East Baltimore Medical Plan, and I had a lot of responsibility for that, and thank God that at that time Dr. Laura Morlock came along, because I was trying to carry out these studies as best I could, and then somehow after she came, and that really fulfilled the team approach there, these studies really became embellished, they became well done, they became rigorous, and they actually got published. And we had a marvelous time in working with that, and I think a lot of the lessons there are still very extinct. So I'm delighted that this has continued. It was an experiment. It's 40 years later, and I can't imagine this place without the Health Services Research Center, and I can't imagine healthcare without Health Services Research. Thank you.
Well, just joining us is Dr. Archie Golden. And Archie, we were just talking about health assistants and health associates, and something you really contribute to. And
sorry I was late for that.
well, we're actually making a recording of all this. So, you know, if you have one of those afternoons where you have nothing else to do and you want to get a good nap, no, when you want to really listen and learn, that's it. We'll have it. Also, Dr. Al Mushlin joined us, and Al was part of the Columbia Medical Plan. He headed up the medical unit there, and you'll hear more from him shortly. Also, I'd like to recognize, I see in the back, Margaret Ruxtelis. And Margaret kept our finances together in those early years, and that wasn't easy. The books were a little slippery, and I very much appreciate your being here. So let me take you into more modern time and just touch on a few things. In 1980, the center grants ended, and so this core support for the Health Services Research Center disappeared. Before that, when we first started, we had core support from foundations, from Rockefeller, and I think Commonwealth, and there was one other that provided core support. And so I found myself as a new director in 1982 very worried about how do you run a center without core support. And for those of you involved in centers today, you probably still have that same sort of anxiety, say, well, how do we do it without core support? And it is a challenge. We did compete successfully, and that's how in the public health model and the medical model we all succeed, and from many funding sources, both public and private. And we took on a greater educational role once we became part of the Department of Health Policy and Management in 1984. I do remember Bill Applebaum is here, and Bill was the chief financial person in the School of Medicine in those years. I remember him sending me a note, and he said, Don, the center has disappeared from the budget of the School of Medicine, because at one time we had core support also from medicine, public health, and the hospital. And he said, do you know this? Is this a concern? And I said, well, it's a concern, but I know it, unfortunately, and that's and so also part of that period of time. We competed in the arena of centers and for more than one, but I wanted to especially note that for almost 20 years we received support from NIMH in a center on organization and finance and care that's really mentally ill. Many people here worked on that. Bill Brakey, I see here, Pam Fisher, Richard Frank, who had hoped to be with us today, but his son is graduating from college, and that is certainly a higher priority. David Salkever also hoped to be with us, but he had to give a makeup class today at UMBC, I think because of that snowstorm that got out of control here. So that center, that provided core funding for a piece of activities, but it didn't provide core funding for the entire center. We continued as a multidisciplinary faculty, and I think our distinguishing characteristic was we tried to maintain the breadth of disciplines and interests in doing methodological and evaluation work. When I became department chair in 1994 and left the center, and Jonathan Weiner really stepped in, which I very much appreciate, as deputy director, we also started a process, I think, of becoming even more integrated with health policy and management. But as you look back in the 1980s, late 1980s, going into the 1990s, the idea of funding general health services research centers had disappeared by then. And people and agencies were interested in highly targeted centers. So mental health wanted a mental health center. CDC wanted an injury center. If you look around the department, NIH, we have a health disparities center. And you can go down, and I remember near the end of my tenure as chair in 2005, I counted up in the Department of Health Policy Management about 13 centers. And suddenly you start to see, well, these entities are highly targeted, and how does that relate to this concept of a broad center? And in part, we found ourselves with centers within centers, which is a little complex, and we found many more faculty were part of multiple centers. And we've done well, but it's very different than the environment that we started out in when you look at the early part of the health services research time. So we're now moving into a period where we're going to have some new challenges in the field, and I think talks to a bright future for health services research, and I would hope our center and all the centers within Johns Hopkins. We need better tools and metrics to make it possible for healthcare organizations to be accountable. Coming back to the Uwe Reinhardt sense of part of the function of research is to provide the tools and metrics by which you can hold the system accountable and to be able to help it understand and improve its performance. It's clear we need new models for delivering health services, and people are concerned that the model we have now we can't afford, and the quality is uneven, and there are disparities depending on race, socioeconomic class, in what you get from that system. And we need greater capacity to utilize the full set of information that comes at the fingertips, and so electronic health records are part of that. I'm sure we'll come back to that. But it's also at the level of population health and individual. And I think we're at the edge of sort of ways to bridge producing information that both helps better take care of the individual, helps inform the individual about their own care needs, and also helps you look at the population and population health. So the questions I would like to see us consider in this symposium is, what can we do to enhance the effectiveness of the center? And one of its critical functions, it seems to me, is a locus for translation of evidence innovations into practice. And so I would hope maybe out of this discussion we get some ideas about, are there areas of faculty expertise that we need to try and attract or develop? Are there issues in the academic career path if you get involved in translation? And I've had that discussion with faculty and have thought about it myself at times. The incentives for faculty and university to really undertake translation in a serious way, or does it sort of stop when you publish the research? What are the partnerships we need outside and within the university? In the early days, we were partnered with health plans, and so we had sort of a laboratory. We had a place potentially to actually apply things. We have now lots of partnerships, not so intense, but you know, also the question is, are they receptive? Are they the places to go? And ultimately, I think in an organization and for the people, most importantly the people who participate in it, the question of the value of the center as an organizational locus for these activities. Do we need other structures that go beyond the center? So to help us get started on this quest for the truth, for the future, it is a great pleasure to have Dr. Denise Rousseau as our keynote speaker. You have within your program a brief bio for Denise, and she has many hats, and I think she wears them all well, as far as I can tell. And she is at Carnegie Mellon. She's an organizational psychologist, organizational behavior person. She heads up the health policy program, health policy and management program within the business school. You can read down through, and an impressive career, and it's ongoing, so not to be stopped here. Let me just say a couple personal things, because I got the chance to meet Denise back, I think it was in 2001. A committee was put together by the Institute of Medicine to look at patient safety, mainly from the organizational point of view, of how do you essentially create and sustain high reliability organizations, hospitals, nursing homes, other kinds of facilities that keep patients safe. And so what was fascinating to me, I got an education in management and what the evidence in management is for high reliability organizations. But what was most striking was there wasn't at that time much evidence within healthcare for high reliability organizations. You had to look outside of healthcare. You had to look at the military. You had to look at Toyota until recently. You had to look elsewhere. And so it was thinking about, how do you put structures in place? And essentially it's asking the question, how do you put structures in place and sustain them that actually make use of the evidence? That is the translation pathway that says, we have some evidence, we've learned something, let's make use of it, let's improve on it, because it's always a continuous improvement process. So it's a great pleasure to welcome Denise here. And Denise is doing something which I always admire, is she's not using slides. So we can either leave this up here, or maybe we can make it go away.
Whatever you like to do. You want to
Uh,
kill that and I'll wander back and forth and we'll create a
Could we
screen?
kill the screen and then we'll let Denise wander? Do you want the lavalier mic?
You tell me what you want me to do.
It is your preference. You can either walk around with this, or you can stand here, or you can do both. What's your?
Let's do this.
Okay.
Oh, whoops.
That should be an
Yeah,
on button.
I
here.
got it, yeah. This is good,
I think.
then I won't be shouting at you.
Okay.
There you go.
Hit the letter B. That does it.
For blank.
Blank. Wow.
I never
See,
believed
I
it
knew I
until
should come to
see
this
it.
to learn something. Never too late to learn.
How's that? Don, thank you very much. This is great. I'm really happy to be here. Thank you very much for coming. I know this is a huge event, and 40 years is very seldom do we get to celebrate something, especially in an academic environment that lasts this long and continues to be as productive. Without ossifying and get terribly entrenched. We're flying in the face of some organizational tendencies, and often it is a battle. Change and inertia are always a kind of dualistically at play. I come here for a couple of reasons. I was really excited when I was asked to come, but I have huge knowledge needs, and I know that every time when I encounter people in another field who are trying to make research happen in the world, I get angles, I get ideas, because it's a hard way to think. Habits of mind, when you're here to generate new knowledge, to actually then shift cognitive gears and figure out how to get people to use it. That's a different side of the brain almost, and even though I know that's a bad analogy, because indeed if we don't have a left and a right brain as we used to think about it, the bad evidence-based analogy holds. We need a brain, more of the brain being used at the same time. And I think, indeed, when we talk about making evidence sticky and practices stick, we are talking about being more mindful, which is actually a cognitive state and also a teaching process. So with that in mind, I'd like to talk with you about ways in which we can make our presentation of evidence and our expressions of it in the world jibe with, work with the hearts and mind of the recipients and the stakeholders and the partners that we have. Because we have to work with what we know to be the facts on the ground about how human beings think and the basis on which human beings behave, if we're going to be able to actually if translation just doesn't mean speak another language, it means use those ideas, we have to work with the best available facts we have. And to a greater extent, it's actually research in cognitive psychology. But the other reason I'm really excited about being here, I do want to learn things, but I sort of feel like it's like coming home to, I don't know if it's coming home quite to mama, that's not right, but coming to the source. I'm very active in an area called evidence-based management, and you go, say what? Evidence-based management, something we don't practice in the Gulf right now. We had that huge leak of oil. We have evidence all around us that management is not very fact-based and not necessarily mastered. Many basic principles about how to organize and get things off the ground. But in my area, which is largely made up right now of practitioners who are trying very hard to get beyond I guess what we say, the evils of selling snake oil are in no way mitigated by the customer's desire for it, actually trying to share things in the world that we know work, and academics who are trying very hard to teach the evidence rather than to teach the Jack Welch story of what Jack did at GE as a basis for an entire class. We're far behind in management where you folks are in terms of health services, medicine, public health, and the other areas of practice that I suspect are reflected here today. So let me say in that, by coming here, I think we have things in management that can be helpful to you, but you will use them probably more effectively first than we will, because we're still pushing that rock up the hill, but we mean to get to the top. So evidence-based medicine has been thought about as probably right up there in terms of most important things that have ever happened in medical milestones, up there with antibiotics and DNA. But the thing that we do know is that fundamental human problems remain. The fact of the matter is that it's hard to introduce change into any organization, let alone an organization with strong professional paradigms about how things should be done, especially when the professional paradigms aren't established consensus, aren't the evidence and the actual practice may not be in line. But there are some things that we can learn from the way people think and behave and from how human cognition works that just might be helpful as you think about how to frame and phrase and target the translation work that you are doing, whether this be print or demonstration or a speech like this, and you're trying to get some ideas out. So the story I'm going to tell you is a story about human cognition. It's a story about human cognitive bias, the tendency to see things a certain way regardless of what the actual stimulus is that's being perceived. It's a story of dynamic conservatism, that indeed we are wired to work against change. We're wired to keep our existing worldview intact unless there's a really darn good signal to us that says, those old rules don't apply, this is a new situation. All of us know how to be new and how to pay careful attention in a radically new situation. The issue is that we most, in our life, don't move a lot from the familiar to the radically new, unless we travel or get up on the wrong side of the bed and the day just doesn't go the way we think. But the issue for us in the change context is that we need to often think like newcomers when everything around us looks awful lot like it did yesterday. It's very hard to change when the cues you're getting say, what you already know will do just fine. So what point, this is a point number one, I don't have any slides, but there is a pop quiz, by the way, to reinforce the points. Did I tell you? And there's not enough people here that I can't just say, oh, you in that lovely red sweater, but now you're safe because I've already picked on you. But the key issue is human beings process information in a way which we call dual process model. How many of you know the dual process model? You can raise your hand and I won't call on you, I promise. Is that a good incentive? None of you know the dual process model. Oh, what's this? Okay, so it won't. So hopefully it'll be fresh. So the basic notion is this: that there's a higher order process, like in a hierarchy, made up of categories. The category could have things like birthday party or celebration at end of day, 5 to 7 upstairs. Okay, that's a specific. The birthday party is probably the better category. We see the world through the higher order categories we've built. So when we tell you birthday party over at Nancy's house at 8, you expect cake and not pie, right? That's part of the category. And if they serve you soup, you're going to wonder, soup? Okay, so that we're seeing the world through a category. On the other hand, so we're going to a party in another country. We don't know what's supposed to happen in this place. We may not even know if it's a birthday party or a engagement party, blah, blah, blah. But in a novel situation, we don't use our categories. We use more directly the data from our senses. What do I see? What do I observe? And so it just so happens that I'm at a party in Monterrey, Mexico, and somebody goes up to a big sheet cake and bites the corner off it. And I'm going, geez, who raised this guy? But everybody else goes, bravo, bravo, because that's the birthday boy. He might have been 70 years old when he bit the end of the cake, but he's still the birthday boy, because that's what you do for the celebrant. They get to bite the cake first. So data, up into my new category. Interesting things happen with cake in the world at the birthday party. I still got cake up there, but now I got a bitten off corner in the mouth of the celebrant. So the key idea is dual processes. In established familiar situation, use the categories that we've laid down over the course of our, if we're a baby, 12 months on the planet. If we're grown up, 40, 60, 80 years on the planet. And when we're in a situation that we know is new, where we get a lot of cues that tell us Don't rely on old information, like when you're newly hired in a brand new company or in work setting. Then we're more attentive to the small details. Newcomers see a lot more things veterans never see walking into the same building, just simply because one sees the world in the categories they had, perhaps the categories laid down in 1969, and the others see the world through the worldview that came when they got hired in 2009. Very different view of the same situation because the categories aren't the same. That's dual processing theory, and that's going to be really important because lots of times we have to work with the categories people already have. It's sort of like doing something very unnatural. Like I'm a Californian, but I had to learn when I came east that you could actually have a spin out on the road when there's a lot of water. It doesn't work with ice, but you're supposed to do what when you spin on the road when you're driving? Turn into the skid. I submit nobody has ever done that the first time they turn into the skid, even if they have the intellectual knowledge. The second time you learn to do it and the car rights itself. The issue is you have to have basically some pre-knowledge to be able to make that happen, but it's not your initial reaction. You learn by experience. We've got to find ways that become natural and native to people and work with them when we're trying to work with their processes. That's going to be a key issue for our stickiness of evidence. A couple of things. Medicine, public health, various areas, and management are in a lot of ways the same predicament. That is that we all deal with the recipients and potential partners in working with the findings that we produce are often people who have many years invested in existing approach. And if they make the shift, or if they're in a situation where there's cause that might induce them to behave in a new way, take up a different practice, at best, they could feel like hypocrites. You know, I've been telling all the young rookies I took in, I've been telling this to my patients, my students, my staff, that this was the right way to do it, and now it's the wrong way. And so there's a distress in that. At worst, they feel like losers. And this is a very important issue, because one of the things that we know in human cognition is that bad dominates over good, which is to say that people react much more strongly to the loss of 20 bucks from their pocket than they do to finding 20 bucks on the street. The gain of the 20 is nowhere as emotionally impactful as the loss of the 20. So losses are more highly reacted to. Part of our challenge in change, and you're a change manager and I'm a change manager, is to work with what we know about losses and gains. And basically it's this, that losses are more painful than the gains are good, because the gains in change come later, when you're better at the new thing you're trying to do, when the organization supports it and there are rewards and you're not just taking a risk on your own and trying it. And there are ways that we can make the gains come sooner so the losses are less bad. And that's going to be part of the process. But you have to, so the two issues so far is dual information processing hierarchy, and losses are more painful than gains are good. So this is the first question. First test is, so what are the two dimensions of the dual process theory? Dimension one is category. I see the world through my categories, okay? Categories are like a lens of your eye. Affect everything you see, but often hard to see the lens. That's a category. And when we're viewing things fresh, we see it through our senses as data. So categories versus senses. And we're trying to help people either shift cognitive gears to go to senses, new things, take it up, or work within their categories and make this change work more naturally. Second issue is we have to manage the losses. So, okay, so we do have these issues. And so one of the things, if losers are going to scream louder than winners cheer, we're going to have to accept the fact that that's inherent in the process. It's not a bad in itself. It's normal. And when we think about change management or translation, pray to God we have normal problems. Because loss management and dual process theory are workable dynamics. They really aren't rocket science, but just like in a lot of things, complexity comes from a lot of simple concepts bundled together, and that's what we got. A lot of simple stuff combining to make the change process a little bit more complicated than otherwise, than we might have expected it to be. So key issue is, before we even talk about the facts of the findings of the research, there are forces in place that motivate people to, at least initially, reject the evidence. It has nothing to do with the evidence per se, but it is something to do with the departure of the status quo and what we call dynamic conservatism. So it's not the evidence, and we often think it's the evidence problem. It's not the evidence. So we just, I think, have to assume first that, let's just assume that the practitioners that we're thinking about and talking about are already got the evidence. They basically know of it or about it. How well doesn't matter for the moment. I'm not going to talk about access to evidence right now. Let's just assume they don't buy it. That's the stage we're at. And from here on out, that's going to be the framework. They got it, they just don't buy it. And that's going to be our problem. And how do we solve that? So what does the research on evidence and judgment and change tell us about what we can do to make the evidence stick and the practices that come from it stick too? So, question for you. I don't know how rhetorical this question is. I'd like you to think about it a little bit. What can researchers, like ourselves, learn from the birthers? Who are the birthers? Yes, I mean what you think I mean. So everybody know what the birthers are? Okay, so these are the people who believe that our president was born not in Hawaii, but on another continent. And despite announcements in the paper that have been copied from the Honolulu press, despite what's in his birth certificate, and the fact that his mom and his grandma, and, everybody born in Hawaii, some people refuse to believe it. Question is, what can we learn from that? They know this information, here's the birth certificate, but they don't buy it. What can we learn from that? Just think for a minute, what are your hunches? Think to yourself first, why do the birthers believe this? First, do you think they believe it? Maybe they don't believe it. Maybe it's just a public relations campaign. How many think the birthers believe that the president wasn't born in Hawaii? They really believe it. And how many think it's PR? Okay, I'm perfectly willing to believe that there are some conspiracies out there, so okay, I think you could be right too. So we do believe it. Question is why? Why do we think that they have this belief? So somebody give me, can I get a couple of hazards of guesses? And you can't be wrong on this because I can't verify either, but I think I have a good evidence-based assessment as to why they don't believe it. Why might they not believe it?
He looks like an alien.
Okay, looks different. Oh, thank you. Okay, so different can't then be us. Okay, somebody else? Another reason?
Preconceived beliefs.
Preconceived. So already had a notion. There's a conspiracy. There's this. There's that. Must not be something else going on. Okay. Well, the concept that I think that these go together, and I think one of the fundamental issues that we're talking about here when we talk about the birthers is similar to the notion that researchers are also others. When we talk about the people who practice, and the people, you and me folks, who go out and we run experiments or talk to folks in the field and do assessments and cases, researchers are often thought of as different kind of people or having a different kind of interest. And in the United States, we're in an interesting situation that I don't see in my colleagues in Europe or Asia, where science is losing the PR war. We're not seen as impartial, partly perhaps because of all those, quote, experts who testify for this, that, and the other in litigations and whatnot. But between Big Pharma, thank you, Big Pharma, for helping us invent the meta-analysis and the synthetic review. The reason we do them is because of the suspicion that the data are accounted for by who sponsored the research. Also, research isn't impartial because, it's all those liberals in universities, or pinkos, it used to be called. What we're surfacing when we talk about researchers as others is an us versus them, in-group, out-group dichotomy. And so this is a very important issue. In-group, out-group effects in social psychology we've known for many years are among the most easiest to induce effects in a group. So if we were just even to go, when I walk and do this, and divide the group in two, I had identical twins, so when I heard, I said, okay, one and the other go, you're group A and you're group 1. Okay, so everybody's kind of, everybody's on the top. Okay, okay, so the A's and the 1s. And I talked, and we talked about the A's this way, and we talked about the 1s that way, and then I had you guys talk to each other, and then, have a dialogue back and forth. What we would find is after about 40 minutes, if I gave you a questionnaire and I would ask you, to what extent do you think that A's are virtuous, public-minded, good intellectuals, and the same rating system for the 1s? If you were an A, you rated the A's very highly. And if you were a 1, you rated the 1s very highly, but not the other. It's a very easily induced effect. And for those of you who are fond of meta-analyses, the effect size across the board is always significant. It varies greatly in terms of how big it is. But the beauty of the in-group, out-group effect is you can induce it for no money. It doesn't cost anything, and probably works with chimpanzees for all I know. It seems to be one of those primate things. So it's an important notion. We are easily primed for group membership, and we care about our standing in our group, and we care about thinking about ourselves positively. So that also means we think about the group we're in positively. Well, in-group, out-group effects are evoked easily when people have an existing identity. Let's say blue-collar Catholic kid, first kid to go to college. There's me right there in a box. It's easily evoked by situations that threaten the identity. Okay. So my husband, who went to a liberal arts school, and I went to the big state school, as soon as he talks about all those kids with that great education at the liberal arts school, I start grousing inside. It's a very bad habit. And I realized it's an identity issue, because then I have my identical twins. We sent them to 2 different schools. One went to the big state school, other went to the liberal arts school. One came in an African American literature major, came out a chemist. Other one went in a psychologist, came out a psychologist. Where did they go? You know. Right, so thank God for liberal arts schools who turn girls onto science. But one of the things that's, I think, very important is, that yes, there are real group effects, but how we think about them and interpret those effects are really, really huge. Think in your own field about how we feel about people, how we interact with and talk to and discuss things with people whose professional identity or background is different. So like a kind of an interesting example I've often found in talk with people from different aspects of surgery, that like orthopedists and vascular surgeons don't believe each other's evidence. How can that be? Says the layperson. But you and I know as professionals, probably what some things might be behind that. So are there any other kind of differences? We don't necessarily believe their evidence. Our evidence is better than theirs. Just think for yourself. How many of you can think of examples of that? Okay. Somebody else's evidence ain't as good as ours. And I think that's very normal. So one of the issues that we're talking about here is in-group, out-group effects are huge in the world and easily induced. And I'm going to combine them with one other facet, because we're still talking about cognition, and that is that intuition dominates our thinking. And when I say our thinking, I mean you and me in our lives, even though we're professionals and I know how to run statistics and do weighted and create algorithms and equations to make a best forecast of what the likely selection outcomes will be if we choose certain kinds of people. You do the same in your own work. But there's a strong preference for intuition over rational or mechanical decision-making. We've known this for 50-plus years in psychology, and despite that fact, clinicians will still say, well, that may be true, but I'm valid. So, okay, moving on. Clinician means a clinical psychologist in the language of my field. That we still tend to believe that the data about the average person, but the person before me is not average. And then some interesting things are happening because of identity, because of preference for intuition, that we have to take into account as we think about making evidence sticky. So all these dynamics are important because we're not actually paying attention in many cases as researchers, attempting to reach other populations, other interested people, or to persuade them, or even engage in a good discussion. We're not actually focusing on the real decision models people are using when they make decisions. Okay? So one of the interesting notions is, I'm going to pit two decision models against each other. There's many models people might use, but we can kind of cluster them into two basic representations. The first one is the one most of us know, which we call the consequence model, kind of costs and benefits analysis. So you kind of look and you say, well, you know, what's going to be the outcome of this approach versus that approach, and the level of investment or effort to get one outcome or the other. What will that be? And then make some choice that somehow is optimal for effort and investment and benefits. But the other model is the more common actually used model. And it's the model that's about those higher level categories again. All right. It's the identity model. And an identity model goes something like this. Who am I? Okay. What kind of situation is this? What would someone like me do in this situation? And Don was nice. He said I wear many hats. You know, I think they're all falling off my head all the time. But, you know, there's a mom hat, and there's a wife hat, and there's an industrial psychologist hat, and an evidence-based management operator hat, and this, that, and the other. I'm sure my own thinking changes as I move from spot to spot to spot, role to role to role, because much human behavior is role-based, and we're cued by the situation to how we ought to act. But when we talk about evidence, it's actually the effect of identity models, really quite powerful and often in very ways they have some unfortunate consequences. So my example of this is in the iteration before AHRQ had a P somewhere in the middle. I don't remember how that worked anymore. And they were in a predicament when Institute of Medicine came out with a conclusion in the 90s, by the time of the Clinton administration, I think, from meta-analyses that indicated that spine surgery should be a last resort where back pain was concerned. You might remember that. How do you remember that circumstance? Okay, so I won't go too much in detail, get the high points. But spine surgeons fought back with a vengeance on this declaration. There were a number of studies that, you know, there's a lot of hot stuff in the literature going back and forth, very vehement discussions, led to a huge lobbying effort on the part of spine surgeons that ultimately led to AHRQ having almost half its budget cut, because there was a lot of pressure on them to not take stands that would have these kinds of consequences for surgeons and for a particular type of practice. What we saw from 92 to 1995 was that back surgery for back pain tripled from 100,000 surgeries a year to 300,000 surgeries in a 3-year period. And I'm not giving you odds ratios, stuff like that. I'm just giving you a basic general summary. The lobbying effort was so intense that even surgeons who bought the evidence and said, I'm going to do less back surgery unless it really seems to be, everything else has been tried, nothing else is working, ultimately found themselves going back on that intention and doing surgery. Why? Because when they referred their patients, they said, I won't give you back surgery. I think watchful waiting and therapy will help you. What did the patient do? Went to another back surgeon who said, I'll take care of that. Let's operate. And so you start realizing that's not doing me any good. I'm not making any money. These guys are still getting surgery. I'm a good surgeon. I should be the one who does it. But think about this issue, though. What do spine surgeons do if they're not doing spine surgery? What is the alternative? I came to the right place. You know the answer. Thank you very much. Somebody always helps you out. Thank you. Thank you. So it's an interesting problem that I think if we're talking about the issue of translation, we want to think about how do we make changes that actually work with the categories people have? What are the alternatives available in a practice mode or as part of a practice community for the spine surgeon under conditions in which this major source of their practice is now no longer going to be there? Okay, so that's a question. Golf is an option. So what do we do when findings contradict our personal experience, are hard to implement because the situation is so powerful? First issue is we want to be thinking about how do we promote a practice improvement model in the way people behave, not a top-down control. Regulation is hard, and regulation is very hard to achieve, as we all know. Just needs to be said. So I'm going to talk about soft power. It sounds Clinton-esque, and I like that, and maybe perhaps also Barack Obama-esque, and I think it's working with the human being, not against them. One of the ideas here is that we know that people are more likely to pay attention to and be motivated by stories than they are by evidence. And point of fact, evidence trumps statistics, effect sizes, and odds ratios. Stories are processed in different parts of the brain than our numbers. You can see this in functional MRIs. Stories are less likely to elicit counter arguments. So if I tell you 9 out of 10 people blah, 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 and somebody tells you about the 10th that they are, that's the counter argument. You tell somebody a story, and it gets around their guard. It's more persuasive because stories have components of meaning and cognition in them that the number doesn't have. Very important issue. Part of the notion is stories can be made vivid. You can rehearse in your mind what was done in the story. I could see doing that. You take away why something happened in the story and say, yeah, I can identify with that. And take away what the benefit was in the story and say, I'd like to have that happen. So I want to talk a little bit about telling stories that make practitioners feel smart, that they get it. Make us feel smart too, because it captures the whole meaning we're trying to get across, not that 9 out of 10. Critical issue in telling a good story is a vivid explanation of the mechanisms that underlie why that's the way to go, why that practice works. Now, I want to tell you one story, and it's a simple little one, but it was very profound for me, and I think it captures some of the facets of what I'm trying to get across. So I study, amongst other things, changing employment relationships, empowerment in employees, empowerment for professionals, look at the effective information flows on people's self-efficacy, ability to be effective at the work they do, create environments that are good for their clients, their patients, and healthy for themselves. I was studying a change in a nursing, in the nursing department of a large hospital, and part of the change process involved nurses participating in councils for quality decision-making, decisions about quality and decisions about clinical care and decisions about work life. It's called a shared governance model, which some of you might have seen. It's a very popular in some aspects of nursing practice. I had studied them for a couple of years and had data on them, actually published some of the data. Went back in with a colleague of mine because her student needed a field site. And I knew that there was more going on, and to have the person power to do it, we went back and we started interviewing people on another matter. I'm standing in the hall of a place where I'd spent 2 years working, and a young nurse comes up to me, and I recognize her, and we start to chat. And she says to me, or I say to her, did you ever serve on one of those councils? And she said, yeah, that was amazing. She says, I was just out of school. And, they'd send anybody who'd be willing to go to serve on the council for the department. They sent me. I was the youngest, and I didn't know, I didn't understand why nobody else wanted to go, but I was happy to go. And she went, and she said to me, I served in this council for a year, and it changed the way I thought of myself as a nurse. They listened to me, and I felt like I represented my department. It was a great experience. So just think about that. Changed the way I thought about myself as a nurse. They listened to me, and I really felt that I did my job of representing my department. What's very interesting is what we had found in this story is actually, I think, an example of a mechanism that becomes very important in the change process, and that is the power of the situation in affecting the person. People need to view themselves positively. We know this from most of the psychological literature. Really care strongly about their standing in small groups. You know, am I accepted? Am I a member? Do I have some status? And we use consistently our own behavior as a source of evidence for what to think and how to feel about it. Everybody knows what cognitive dissonance is? Cognitive dissonance, we got that in psych class, right? Okay, cognitive dissonance is a sense of pressure when the attitude and the behavior aren't in line. So if I'm saying one thing and doing another, I don't feel very comfortable about that. It's the idea. We often take from cognitive dissonance the wrong conclusion in psychology, which is to say, people often think if I change your beliefs, I'll change your attitude. That's a long road. Lobotomies would be easier. So here's another basic principle. Behavior leads to attitude more consistently than attitude leads to behavior. And I want you to think why it is that behavior might actually be easier to change than attitude, because that's the truth. That's the consistent evidence in research and psychology, and it's critical to research on change. That behavior changes attitude. Why is it easier? I'll assert that as the point for the moment, then I'm going to develop it. Why is behavior easier to change than attitude? Give me some reasons why you think that might be possible. Who can I call on? The ones and the A's. You're a very lively soul over here. You've got a great time on too. So why might behavior be more malleable to some extent than attitude?
Because if people change their behavior, then they have to change the way they think about what they're doing.
Oh, okay, so the behavior puts pressure on attitude.
Yeah.
Okay. Well, wouldn't attitude put pressure on behavior? I think like this, but I act like that. And why do I keep acting like that? Why might I keep acting like that? Other people around me think I should act like that. Feel this way, can't act like that, they won't let me. But once I behave, all I have to worry about is my own attitude, my own head. I'm already acting that way. Another factor, why might behavior be more malleable, more easy to change? Nice red sweater, yes?
You can create rules that force people to act a certain way.
Okay, we can do things in the situation that cause people to behave differently. You can make rules. If you don't want your kids to be driving in the car, you take away the keys, right? If you don't want them to drive your car, you can put in constraints. We have control over situations that others are exposed to as well as ourselves. We don't have a lot of control about what people think because it's a private matter. We can't get into their heads. So it's much more publicly accessible. So a key issue when we think about change is that behavior is the target, not attitudes. But if you think about how a lot of translation of research is put together, it said something like, in my field, we're rampant, terrible at this in management. We'll write in the implications for practice section, people should be more aware of X, more aware of the fact that your employees need feedback, more aware that it's important to give follow-up reinforcement after somebody has performed well, or give feedback soon after a problem has emerged and don't keep it off until later. It's lousy advice because it's not awareness we want, it's their behavior. So the issue is behavior leads to attitude, practice leads to belief. Think back now to the nurse at that hospital who served on the council and then thought differently about her own practice and her own capabilities to represent her department. She wasn't there because of her attitude. She was there because she was unwilling. But the practice, the behavior changed how she thought. We have made, I think in many cases, this is the collective we, I'm going to go to the last couple of points, what we call in the field an attribution bias. Attribution bias means that we may be biased in our causal reasoning to attribute problems to one set of causes, and they're not necessarily the right set of causes. That's attribution bias. The fundamental attribution bias, we're replete with it in psychology, psychological studies, basically says that people are inclined to, individuals tend to attribute the behavior of others to the person and my own behavior to the situation, right? So other people act the way they do because it's your personality, and I act the way I do. Well, if I like it, it's because I'm smart and gorgeous and this, that, and the other. Obviously, these are rhetorical issues. I'm actually built for famine. But in any case, but the issue is, when I do something I don't like, it's because the situation made me do it. We have issues where, to a great extent, our behavior is what we need to induce if we're trying to get different understandings in people's heads. We need to build situations that themselves are stronger. I'll call it tweak the environment to make it easier for people to behave in the ways that actually will reinforce more deeply over time the kind of learning and the kind of practices that more fully reflect effective practice, effective performance. And that's really the issue here. Get some initial behavior change so that subsequent attitude change becomes a virtuous cycle, and behavior then changes further. So an illustration of this, you guys, everybody's read Rogers' Diffusion of Innovation, right? And we've all read The Tipping Point. Okay, it's good, right? They're all very good, and actually basically very evidence. Rogers is a researcher, Malcolm Gladwell, a very good translator writer. He's really getting at some realities here, which basically are the idea that you need enough of some people doing things differently for most people for the majority of people to be willing to change. That's how social influence affects things. If we build strong situations where it becomes a little easier for people to show the right behavior, we're more likely then to get peer influence on those people who otherwise would be reluctant to engage in that behavior. So my argument here is tweak the situation, grease the skids, and a big issue for change management, bundle up. Do multiple things at the same time to make the situation strong for the behavior to be evoked and continued. And here's my illustration. It's a study, a set of studies that are recently published. The book is, I think it's called The Blue Zone. It's called Lessons from People Who've Lived the Longest. It's an experiment that's been, or a field test being done in a Minnesota city called Albert Lea, and the study is sponsored, done in collaboration with the University of Minnesota Institute on Aging. And what they have done is they've gone to regions in the world, and certainly regions in the United States as well, where people live longer than most other places in the United States. What are they doing? Well, they identified the healthy behaviors. I know this is selecting on the dependent variable. It occurred to me right away too, but this is the tale. These guys in the places that live longest, yeah, they eat more vegetables. I got reinforced by Dawn at lunch for not finishing my sandwich. I knew that was good. As if you stop when you're 80% full, as opposed to eating it all, you'll be healthier. People who find natural ways of moving, all right, as opposed to, well, I'll exercise for half an hour. You know, what if I walk between offices and between buildings all the time and, you know, walk to work? That's a much more, human effects are larger. Have social networks that are supportive, do work you care about, have spiritual activities or something that really kind of emotionally centers the person. There's a lot of evidence, at least descriptive evidence would say these are correlates of living longer. So in the town of Albert Lea, a set of commitments were made to formulate the environment so that people would engage in a radical change without realizing how radically differently they were behaving. This sounds pretty good. This is like the lobotomies I was talking about. They changed their lives in very interesting ways by putting sidewalks where there weren't sidewalks before on the way to the schools, putting more sidewalks into communities that were near schools. Kids would go to school on what was called a walking school bus. So the, quote, bus driver, I guess it's like a herder of cats, takes all the kids to school, and they're holding on to the rope that keeps them together, and they walk to school from their house rather than taking the bus. We have 50 community gardens put in place. So people are eating the vegetables, they're planting the gardens, doing things together with friends. Healthy choices are offered at restaurants. Fundraisers sell wreaths and not candy. And what we found was basically about 25% of the population changed their behavior in some way, shape, or form in consequence of this bundle of interventions. 21% drop in absenteeism at the, across the board according to local companies' employer records. The average person lost 3 pounds of weight. There was a 49% decrease in city employee health care costs in this time period. What we have in such a story that I'm telling you is something that's very important if I want to get at the mechanism. So one of the mechanisms is, okay, it's the environment that's changing. There is message to people that we're doing this, a search to get their commitment, but it's the environment that's different, and it's making it easier for people with the commitment to change. But an important issue here is they shrunk the change. If I tell you, eat healthy, live a great, healthful lifestyle, and here's the 20 aspects of that, what impact does that have behaviorally? Oh my God. Well, we know from human decision making and from human judgment that most of us cannot pay attention and think about and make trade-offs between more than about 7 plus or minus 2 different bits of information. I give you a list of 20, I may see 1. On the other hand, I give you a list of 5, you might be able to think about that and say, well, I'll do a little of this and I'll do a little of that. All of a sudden, it becomes more possible. If we're giving in translation a laundry list, we are not helping people cognitively get their minds around the basic points. I'm not saying throw stuff away, but I am saying organize for maximum optimal cognitive effectiveness. Go for the top 5 or the top 6 and make those the focus over and over again, working with human cognition. If we're going to prepare ourselves to be a change agent, and we have to be change agents if we're translators, because if we're translating, we need to think about ourselves as change agent. We need to do the things that involve both reason, here's why something works and here's the results, ethos, or credibility, right? Here's why I should be believed. And one of the most important things we know, and Don and I were talking about this at lunch, is the thing that people believe experts who are like them. I would not send a nurse to talk to a doctor because a doctor won't listen to the nurse. We had this big decision in our unit. We have a healthcare management program, executive program. Could we let a dentist in? Well, we knew that was asking for trouble because doctors don't want to talk to a dentist. They want to talk to doctors. Okay, I'm going to play in that territory until the world changes. All right, if that's what it takes, give them a representative who is like them. People's great tendency, it's an egocentric bias, is to assume that other people think as they do until evidence comes to the contrary. So the person who's like you tells you this one thing that is different. You just assume they agree with you on everything else. That's okay, we can work with that. Just let them pay attention to that one thing that's new and different. But how do we know to do this? Well, I think there's a couple of things that have to happen. I mean, one of the issues is, as I told you when we talked a little bit about the different kinds of surgeons who don't listen to each other, we do need a level of respect that's been just kind of maybe not given a lot of attention. How do we create respect between researchers and practitioners? How do we reduce the distance between the other and ourselves? Well, I think it's very interesting that one of the issues that's often is the case with the other is that the distance of the other gets more and more powerful and salient the more threatened we are by what the other says. And I'll go back to my example of the birthers. President Obama has had a very interesting time in history for a host of reasons, the economy and American politics and all the rest. But I think there's a very interesting process whereby the kind of identification and connection that is often given, has been given to some celebrities who have backgrounds not all that different from his own, he hasn't been accorded as consistently. And I think of the example of Oprah and Colin Powell. Never met anybody who doesn't love Oprah. You know, Hispanic, white, Chinese, Oprah's cool. Why? She makes people feel good about themselves. They don't say, oh, I wish I were as rich as Oprah or as skinny as Oprah. I might want to be as rich, but I don't resent that of her because she's got a weight problem. I have a weight problem. Under the skin, we're a similar kind of person. And I think a lot of people feel that. Maybe she's our better self. So it makes for white people This notion of really loving and caring about this person who otherwise might be so different. She's not different. She's a part of the we. But somehow, in the case of the president, there's a threat, and it could be political views and all sorts of things, but I also do think there's identity politics that's involved. That some people are really uncomfortable that an African American could have better standing than they do and be so smart. That, that's the kiss of death, just to be smart on top of everything else. So those are the kinds of issues. Threats to identity are important. We all live it. It's part of the human process. And it really, I think it's less about race and more about personal security, though it's not about race. Critical issue for us is how do we work with that? How do we create decategorization so the researcher isn't the other? How do we show genuine goodwill to the person whose background is really different? Well, part of the issue is, do we know what the role of a practitioner is? And this is a real issue for us academic organizational people. Do we really show a genuine interest to the problems these managers and executives have in life? Or am I resentful of them because they've just got so much money and they're a pain in the neck too? I have to show them empathy because else I'm not on their side. I'm not giving them respect when I'm doing that translation. One of my students, a wonderful guy who's at George Mason, Matt Cronin, did his dissertation on a topic that's commonly thought about but very seldom studied, and it's called respect. What is respect? It's conveying that the other is worthy of attention. Now, how do we do that? Well, part of the issue is spending time more and more in the field or with practice, spending time listening to people who are actually doing the work and what they struggle with, and what they identify with. So if we're presenting ideas, we're working with that identity to the extent that it can be part of the greasing of the skids. What are the actions then that we could take using all these concepts? Well, I've got, in the spirit of 7 ± 2, 5 actions. I was thrilled years ago when Clinton was giving a speech, and he went and he was talking about healthcare policy points. The whole thing obviously didn't go very well, but the speech was great because he stopped with 6. I said, evidence-based, good. First issue you already know about, which is we need behavioral supports to guide what practice would do. And so this is the example of tools, checklists being very big, and other kinds of supports. When Don Berwick did that wonderful project that reduced errors in all those hospitals, one of the things that he was very good at is he had like 6 points of intervention that he focused on, and instruction, checklists, tools, to basically help shape people's behavior to reduce the issue of incidence of medication errors, so behavioral supports. At the same time, though, let's think the cognition part, and that is to make our evidence cognitively and emotionally sticky, we have to not just rely on a numbers tale. We need to tell a good story. And a good story is, in the experience of our audience, somebody that basically simulates what it is we want them to do. So, okay, I want people to report a medication error, and here's what you would do and why you would do it. Simulation and inspiration, what to do and why in the story, and a way of showing then what the positive consequences are, what the benefits are, the rewards are for having engaged in that action. Successful change management speaks to people's feelings. I teach change management. We do all the rational, the diagnosis, we get the data, we do gap analysis. But when it comes to implementation, that gap is not a seller to people until they feel it in their gut. It's not the number. And so, the critical issue here is telling a story in a way that motivates people. Go back to an illustration. There's a great case. There was a case about putting a company that put metal tops on jars. It's called the Continental White Cap. They're the people who used to put ketchup bottles, White Cap. They made all those. Something has happened to ketchup bottles in the last 20 years. Do you know what? They're in plastic, right. The FDA in the 80s, late 80s, approved the use of plastic for foods. And so that was a big hit to a company that makes white metal tops. They had their sales data. They would show it to people. Look, our sales are going like this, not a good thing. And people would say, oh, that's okay, not a problem. Our sales have always been cyclical. Wait till Christmas comes. Wait till 4th of July comes. People will buy more ketchup. Not a problem. they weren't grokking the idea that plastic was really a game changer, as I like to say in business school. So what does the plant manager do? He gets smart. He says, well, okay, you're not believing any of the tales I'm telling you, and you're not buying our data. Let's get a bus. Okay, they get a bus. Shut the plant down for 2 hours, like 4 to 6 in an afternoon. Take them to the local, I think it was a Kroger, because it was in Chicago. And they have the sales manager, the HR people, all the folks who work the line making the metal tops. Hop on the bus. They're given a flip chart, not a flip chart, what's that thing? Clipboard, and a notepad. Go down the aisles and record the nature of the container in which this product, mustard, sauce, mayonnaise, blah, 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 is, and report back. They all walk down the aisles, they record things, they go back, they get on the bus and they do a huddle. Plastic, 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 plastic. Sometimes you have to get them to make their own story. But when people create their own story, they do believe those data. And it was a major change for this organization in its ability to sell the idea. So we're talking about making things sticky by creating stories and experiences that people can't deny. Forget, analyze, think, and change the way you and I were raised. Let's talk about how you and I as human beings often do it. See, feel, and change. See, feel, and change is what we're trying to evoke. Reduce the threat and anxiety that people experience when the change comes up. If a change is articulated in a way that solves a problem I already know, it's a heck of a lot easier to sell it than if it solves a problem I don't think I have. Reducing people's uncertainty by helping them be successful at something is really critical. One of the things that we know is that very often when we put a change in place, we have to do it such that we do the initial set of changes in a way that we can't screw up. We do it in a way that there's multiple reasons why this particular change will work. In the case of making a change from an evidence-based management perspective, I can tell people all sorts of things that they should be doing to improve their selection processes. But if I'm going to do a pilot test, one of the things that I would very likely do is I would have them select people on what the evidence says. Select salespeople by screening on extroversion and conscientiousness, 2 of the big 5 dimensions of personality, because extroverted, conscientious people make great salespeople. That doesn't necessarily mean they are good salespeople, it's just that they make them. Okay. Then train them to be persuasive. Then set some challenging goals with some incentives. Then it's a no-brainer. I'm going to have a good sales team. My intervention is simple. It's 3 things: selection, adaptation, develop the behavior. That way, I help make them successful. We talked about shrinking the change, boil it down to a set of things, maybe no more than 5 or 6 basic actions that are easy for people to do with supports. And then the last issue and my last point, the whole notion of creating, I guess we call it a social nudge. It's the tipping point that Malcolm Gladwell talks about. It's somehow restructuring an aspect of the work environment so that the information that people get that comes to them, the social proof that tells them, here's how you do this, becomes so much easier to follow. That might mean the idea that you seed some sort of peer pressure on people to follow a certain kind of practice. It might be like in the case of the nurse. We make sure that everybody in the group does some time being involved with a new practice. Everybody rotates, not just one person being sent. Because if people haven't participated in the change, they don't fully understand what it entails. Once you've at least gone to a pilot, seen it done elsewhere, new information comes to you about how that change works. People who've been involved in the change have a different social network and a different involvement than people who are observers to the change. More people with a little exposure is better than a few people with a lot, because it changes the information that people have. And lastly, where possible, design the practice that we're trying to promote to be the default option. So in Pennsylvania right now, our issue is trying to get organ donation to be what you have to decline when you get your driver's license, as opposed to what you have to check to get your driver's license. Because we know that people are much more likely to endorse the default than they are to check something that is an alternative from it. We're talking about creating out of what are right now weak situations strongly supporting status quo, enough changes and support in the new environment and advocating that in our translations so that whatever new behavior we get begins that virtuous cycle of changing attitude. On that note, I'd love to take your questions or chat with you because I thank you very much for, you passed all the quizzes that I gave you, so you did very well. Thank you.
We could take a couple questions, and we're going to have a break, and then we're coming back. And so, questions, comments? Or do we have all the answers now? We just have to be able to apply them. So are you available to help us do this?
Of course. And I think one of the interesting issues is focus on a couple of things and just really work them, right? How do I get a little bit more behavior? Because people start thinking differently when they do things differently. Yeah. Yes, please.
So if we wanted to change the behavior of clinicians, it sounds like the best thing we could do is to have very large-scale trials of very small changes.
Yes. I think it's a great insight. So going back to the in-group, out-group idea, little things that are very clean behavioral effects, have clean behavioral effects. Yes. You know, so it's the whole idea, you know, if you want somebody to, you know, do something differently, maybe take away the tool that they use to do the thing you don't want them to do, leaving everything else the same, they're going to have to do something different. So sometimes we talk about this as it's kind of like in chaos theory. It's from small interventions, large changes come because there's so many iterations of that set of events over and over again. So I'm always for the easy way. What can I get to have people to do a few things differently? An illustration that which I found. I say, I'd like you to do one thing this week that you haven't, you know, or this month. It's better to set it for a little bit more time. So tell people that I'm working with, okay, at the end of every meeting, I'd like you to ask 2 questions. What did we do at this meeting you thought was really useful that we should do again? And what had happened in preparation for this meeting or at this meeting that you think we could improve on, and what would that be? The first time they do this, it feels really cheesy. Even my provost, he sees me in the room and he goes, okay, I'm going to ask you this question. And then he's got this grin on his face that makes me want to slug him. But he does then say, what did we do at this meeting that you liked? And what did we do at this meeting we should have done differently? What's amazing is the amount of learning you get about how to improve a process. So if people would simply just do the whole notion of what did we do today that was good? What could we do differently next time? And keep asking that, you get tons of ideas. And it's one little intervention that, you know, the cost to you is you feel embarrassed the first couple of times, and then they look at you and they say, oh, there he is again. He's going to ask us those questions. But it affects the conversation. So small things repeated a lot. Yes? Comments or thoughts? The incentives aren't good, as I know you want that break. Yes, please.
Kind of putting Don's thought together with yours, what skill sets do you have to bring together into a center or whatever to really work with this problem, this situation?
Besides stamina? Because persistence is very important. A lot of things come from small interventions, so you don't get big wins visibly, but that's the one thing is the persistence on small tweaks that change the environment. Sorry.
The discoverers are maybe not the best people to implement these things. And so you're talking some kind of a collaboration, I assume.
I think you're exactly right. I'm sorry, Don, I should let you answer this as well. But I think one of the critical issues is closer ties to the people who will practice is absolutely critical. How can I know what story motivates them? How can I know what their identity is? Or what's the low-hanging fruit, easy change? They'll know it far better than a scholar, academic's going to know. That's a very, very good point. And that's part of the respect, that I just won't assume that I could tell you how to fix it until we've talked and we help each other.
It's not enough on a unit in a hospital, for example, where a small change, might get attention. But what about a large healthcare system challenge, health reform, changing healthcare in East Baltimore, or Maryland? What are your suggestions?
Well, one of the things that's always amazing to me, let's say hospitals, is hospitals are the places that in which you can promote innovation, but you can't promote diffusion very easily. So you can have a marvelous ICU, state-of-the-art processes, state-of-the-art collaboration, next door to another ICU, so maybe one's cardiac and the other's general surgery, and they're in the Pleistocene because they don't talk and they don't learn from each other. And so part of the issue, I think, is I think in the process that I would use, I think that we do need process interventions. This will play to your industrial engineer part. Make a few changes, work on them and learn from them, and then share that information with others. Conversations in hospitals are not about making innovations work. There are lots of kvetching, a lot of complaining, a lot of negatives, which is necessary because the negatives will be here. But what's that? What do we go after that conversation? We let that stop us. And so I'd say, how do we make this work? And to get better at implementation. I almost don't think it matters what gets implemented as long as it's implemented well, because you'll get processes that over time are more adaptive. I guess that would be my approach in thinking about healthcare. Because whatever we implement has to be native to the place it'll be at, else it'll just be top down, and that's already not a good thing. Yes, please.
I just wanted you to clarify. I'm hearing two things. One is small changes.
Are good.
The other is put a bundle.
Okay. Okay. Thank you for that point. I don't think of them as mutually exclusive, but you're right to raise that issue. That's helpful, and I don't want to be so confusing. First thing is to recognize that when you make a small change, you want the kind of small changes that are hard not to do. So it's not just do anything that's little, but it's choosing something that has a direct impact on behavior. I'm not going to order this anymore. I'll see what happens. That kind of a thing. So you're thinking about the kind of very behaviorally tied changes that you can make. You can't get this order unless you go online to get it. You can't order it through a person anymore. That's the way in which a lot of things happen in hospitals, right? You have to go through this channel. That's a very powerful behavioral change. There's no other way unless I go through the online system. So that would be the single intervention kind of example. If we want behavior to stick, one of the things that's very clear is that we're not in we also often very controlled by, people say by government, by regulation, by lawyers, by this. Fact of the matter is professionals still have tremendous latitude in how we practice in the day-to-day. Quite striking how much latitude we do have. But so one of the issues is you need multiple reinforcers to get behavior to change in these environments where people have lots of choice. So when I talk about a bundle, I'm usually thinking about both changes that target the behavior explicitly. So we might have training so that people do something differently, and we might have checklists that help them follow a particular protocol that's good. But that bundle also then includes supports, like maybe some monitoring to give feedback. So are we, it's like the hand washing thing. Well, exactly how many times do you wash your hands as often as you should? When we monitor this, we find, of course, people will radically overestimate how often they really do what they should be doing. The parts of the bundle are the supports of the primary interventions. So do we do periodic, retraining? Do we have a manager who knows to call up and ask about, well, how are we still doing this? How's it working for you? And seeks feedback. That's what I mean by a bundle. We often look for silver bullets. Managers love them, and I think people in healthcare like silver bullets. There probably are a few left out there, but this change is not a silver bullet. Change is a bundle. So the situation becomes harder to behave in another way, but in the direction of change.